advancing clinical safety, quality, and healthcare governance in SGH. Prior to this, I have been in the education space in graduate medical education, where Sing Health or Singapore in general transitioned to the new framework of residency program under ACGMEI. Which some of you may also be familiar because I believe you're also in the international ACGME. So I'm a physician and nurse by profession with over a decade of experience in healthcare leadership and education. I'm very passionate with system level transformation, and I'm committed to building a strong culture and safety and driving sustainable improvement in patient care. With me today, and Jeanie will be sharing much more about our journey in clinical risk management. So she has a background of over 10 years of experience as a senior clinical pharmacist. Currently, leading our clinical risk management in SGH, where she implements proactive strategies to enhance safety and quality. She transitioned from a clinical pharmacist to healthcare management and has gained expertise in this space, root cause analysis, and also enterprise risk management. Same as me, we're dedicated to fostering strong safety culture and advancing risk-informed mindset. Yeah. Before we proceed, just minor housekeeping. Next slide, please, Jenny. Yeah, so whatever contents we're sharing is for general info and educational purposes. And we're also in our own journey and does not constitute professional advice. Our opinions may not necessarily represent our organization. Okay, next slide, please. Just for the rest who may not be familiar with how Singapore is organized, this is the topic that we'll be covering for today. I don't need to belabor it. Let's go to the next slide, Jeanie. Yes, thank you. Yes, for some of you that may have not been in Singapore and may not be familiar with our healthcare landscape. So Singapore's public healthcare system is actually organized into three regional clusters. We have National Healthcare Group, the red circle that you're seeing, looking into central and western Singapore. We have National University Health System, the circle that is in blue, which looks into western Singapore and anchored by NUS. And lastly, Sing Health, which is the orange bubble, which is more responsible for the eastern and central Singapore. So our cluster model ensures that the care is regionalized, integrated, and accessible across the island. We are a small country, but this is how we are well structured by the government. Singapore Healthcare Services, which is Sing Health, is the largest and oldest cluster. We are actually comprised of 4 hospitals. So we have Singapore General Hospital, Changi, KK Women's and Children's Hospital, and Sengkang General Hospital. We have 5 national specialty centers covering cancer, eye, heart, neuroscience, and dental. We have 8 polyclinics with further expansion ongoing. So Sing Health, if you can see from the top end, is also serving as a major academic medical center with strong partnership with Duke and US Medical School. Next slide, please, Jeanie. As an AMC, the convergence of clinical care, education, and research enables us to pursue innovations and deliver better and more accessible care to our patients. So we are united by our common purpose, which is patients at the heart of all we do. SGH, if you can see from here, Jeanie, you can continue to just click on the slide. So it will show the other centers. Yes, thank you. So SGH was established in 1821 and is the flagship hospital of the public healthcare system in Singapore. So as I've mentioned, together with the 5 national centers, we are co-located in the SGH campus and providing comprehensive range of medical services within one complex. We are continuously evolving as well. So next slide. SGH is also undergoing a multi-phase transformation to meet future healthcare needs. So in our phase 2 transformation, which will be completed around 2035, we'll expand capacity and services with new clinical blocks and outpatient facilities, integrated research and education facilities, an enhanced model of patient-centered care. So this redevelopment further position SGH as the next generation academic medical center that integrates care, research, and education. Next slide. SGH has also been consistently ranked as the world's best hospital, and we pride ourselves in this. And we continue to dare to dream and do what has not been embarked on. So SGH has been placed in the top tier globally, and reinforcing our reputation as a leading academic healthcare institution in Asia. So this is where we are, and as I've said, we continue to dream. So for this particular webinar, we will be focusing more on clinical risk management. And in order for you to understand how we are further organized in terms of committees, so in SGH, we are structured differently. So we recognize that risk, safety, and quality are fundamentally interconnected elements that require coordinated oversight. From the screen, you may be able to see that there are 3 different councils and their integrated leadership approach so that we ensure consistent messaging, coordinated implementation, and comprehensive governance of safety and quality initiatives through our SGH. The leadership for our 3 committees driving safety and quality will be our Chief Risk Officer, Chief Quality Officer, and our Chief Operating Officer. So this is how we organize. Zooming into Patient Safety Council, which is on the next slide. So in 2021, Patient Safety Council in SGH was established, representing a strategic shift to a more comprehensive safety-first approach. The PSC was established as a platform for key leadership from different clinical domains, from nursing, allied health, pharmacy, and medical, driving strategies of clinical safety, risk, and quality for the organization. The council is a strategic platform. Next slide. However, in order for the strategy to be implemented or to be operationalized, there is a need to have an office that drives this strategy. So, and this is who we represent, the Office of Patient Safety and Quality. We have a structure that is clinically led, administratively driven, because our space is more on clinical safety, risk, and quality. And it is important to have that insight from the clinician, and then us as the administrators, which is on the next slide, driving the implementation and solution, maximizing both clinical expertise and operational excellence. I also want to emphasize in this slide that OPSQ is actually, given the unique demands of clinical safety, something that I would like to share with the rest is it is important to bring in staff or team members that have clinical background in terms of, and then combining this clinical understanding with the administrative role. So our team comprises of diverse range of experts, including nurses, pharmacists. We also even have a traditional Chinese medicine practitioner, medical technologies, and doctors in our team. So these professionals serve as both in leadership and membership role, bringing their invaluable clinical expertise to our administrative function. So what I'm trying to say is we are organized more in a dyad where you have clinicians that are able to provide that clinical inputs because they are continuously practicing, and you are partnering that with our team, which is the administrative team that have also clinical understanding. This dyad allows us to operate more in an optimized and an efficient way. So zooming into where Jeanie is, it's under the clinical risk management. If you can see, OPSQ is organized into 5 different departments, and our design is deliberate because we would like to build the depth of expertise within the different pillars of safety and quality and risk, while we also optimize a T-shaped organization where we share the expertise across the whole OPSQ. So with that, I'll pass over the mic to Jeanie, and she will now continue on with the topic at hand. We will entertain questions later on if you want to find out more about how we are organized. Jeanie, pass on to you.
Okay. Yeah. Can hear me, right? Okay, so I will start with our team is actually clinical risk management, in specific that we are looking after the clinical domain, like helping the doctors at the frontline, nurses, and many other medical divisions to look after the risk in SGH risk landscape. So our team here is to enhance risk management practice at clinical area, and also we are trying to build more on the risk aware cultures across the entire organizations. Okay. So the first questions that we always ask is, what is risk to you? So if by the book definitions, risk is actually uncertainty. So as long as you have anything unsure, uncertain, then it could be the risk. But most of the time when we introduce risk management to the ground, they are very unclear on why do I have to do risk. Risk is not something that is my priority. So we are trying to tell them that actually we want everyone to feel comfortable with risk, because with a successful risk management, then our organizations can grow further. So for risk is not actually a harm. We just want everyone to build the cultures and the mindsets of a proactive risk management. Then we can prevent any harm or errors happens to us. So we usually get some inspirations or examples from aviation. So we take this example of the Jeju air crash that happened early this year. So this case happened in one. So this South Korea air crash, actually there's 179 dead and 2 has been rescued from these incidents. So the first questions that we ask is, why was there a concrete walls that built at the end of the runway? So everyone, of course, when you build the wall, you will have a very reasoning, very concrete reasons on why I built that. So actually this wall is built because they want to serve to elevate and keep the level and array of the antennas used for the aircraft landing, because the land that they built at the one airport was sloped. So most of the pilots are familiar with the airport, admitted that they long had mistaken that the wall is actually harmless. It's not a concrete wall, and they would not know that an event could happen. So from our point of view, we will think of, what if all the pilot was aware that is a concrete wall? Will they still will we save more life? So we bring this closer to us, to healthcare, is one another example that happened in Singapore, which is KK Hospital, which is under Sing Health as well. So this case happened during the COVID period. So KKH Hospital implement a safety protocol during COVID period. They built an outdoor screening tent and security barriers to try to minimize any infectious risk. They do not want the patients or caregiver to enter that area. So, however, there's one night, this mother tried to drive an unconscious child, trying to find the entrance of the children emergency. However, because of the tent that we built during the COVID period, the mother actually drove to the wrong entrance, where she saw there's another gynae center. The signage is more bright, so she thought that that's the entrance of the children emergency, which has then resulted her to go to the wrong entrance. Then she has to wheelchair the child to the correct emergency, which resulted in precious times being lost during a very critical situation. So what if we apply risk management concepts when we build these 10? Will we prevent these events happen? So we try to give real case scenarios to make people think of why is it so important to have this risk mindset. So the other questions that we ask is, we have to take smart risks. It's not that with a risk management mindset, then I want to avoid any new initiative, or I want to avoid any example, AI is growing now. I want to prevent risk, so I do not want to learn about AI. So this is not the approach. So why we want to do risk management is we wanted to take smart risks with a proper control, or we call it as mitigations in place, so that we can prevent any we do have control in place to prevent any risk from happening. So a successful risk management will actually enhance our patient safety and also safeguard our work, and may offer opportunities for a greater effectiveness and a success for your organizations. So this is not specifically taught in medical school. So when we try to give a lecture or talk or workshop to the ground, to the clinicians, the doctors in the front line, they do not understand how to predict future risks. So most of the time we have to use real case scenario to explain to them. For example, if you want to go travel overseas, what are the risk management that you have done? So for example, I will prepare insurance. I will buy insurance if I miss my train or if I miss my flight. So what is my alternative? So we use all these real case scenarios to explain to them, actually the risk mindset is in you. It's just that you do not know that this is a mitigation that you have in place. Yeah. So another for SGH, we actually require all department and divisions to do enterprise risk management as part of the hospital business continuity plan. So for enterprise risk management, later on at the end of the presentation, I will go in detail on what is this about. So for us, we want every clinical divisions to do a risk register, which is one of the risk management tools that I will explain later on, and ERM review. And the output of all this risk management is actually key in a standardized template or report. We call it as a key risk mitigations report that we have been using it across the entire Sing Health. So currently for SGH, there are a representative from our patient safety which we appoint them as patient safety officer for every divisions and department to do this patient safety work, especially in clinical risk management. So another example that I want to show here is by comparing during SARS period or Ebola outbreak and the recent COVID-19 pandemic, then we can actually see the impact of proper risk management and why is it so important. So back in 2003, during SARS period, many healthcare facilities were actually unprepared for the crisis. And risk management practice at that point of time is not well established yet, especially in healthcare area. So it could be very well established in like law or banking or insurance, but it's not so well established in healthcare. So we face significant challenges. We are lack of preparedness for the plan. So when crisis happens, so what do I do next? I don't have policy in place. I don't know what is the training. There's no training given. I don't know how to wear my PPE. There's not enough resources to buy the PPE. So there's very poor communications. Like a lot of people started to get panicked and confused. So this happened and led to a lot of the infectious rate, high mortality, high morbidity, and highlighting the critical need of improve. There's a need to improve preparedness, good improve risk management in healthcare settings. By comparing SARS to the recent COVID, actually for Singapore, we are actually named in many newspapers that we are very well prepared to fight this virus. And healthcare risk management practice is actually significantly more developed compared to the SARS period, and we know how to respond to the crisis. For Singapore, we actually have this DOSCON level that our government have put in place, and most of us able to deliver this message to the public or even our patients on how to do a proper how to wear your mask. You have to wear mask, and why you have to wear mask. And we even have enough storage of PPE, and we do not have problems with procurement issues at that point of time. So the technology at the point of time where we're having COVID, actually we are already having quite a bit of telemedicine, which is a video counseling to see a doctor. So we want to reduce the human-to-human contact to prevent the spreading of the COVID virus. So rapid activations of response plan. Okay. So experience learned from past crises have led to a better preparedness and response strategy. Ultimately, we save a lot of life. Our staff infections rate is low as well, and we're able to improve our healthcare delivery during emergency period. So this is the summary of what is the difference compared to both, and the lessons that we learn from this is risk management enables us not only to prevent harm, but actually for us to able to respond smarter and faster when the risk happens. Okay, so for the next phase is about risk. Is it a harm to us, or we use this to see it as an opportunity? So rather than viewing healthcare risks purely as a harm to us, we should consider them as an opportunity for us to improve and grow. And this can lead to more constructive approach to healthcare delivery and also patient safety. So if we look at a more positive way, with proper risk management, we actually has better safety measures. We're able to learn from opportunities and the resource optimization. So I know where do I locate my resources, and innovation. So for innovation is very important, but we need to make sure that we have risk mitigations in place. We know how to handle if these innovations fail or this robot failed, what is my downtime planning? So overall, our aim is to improve patients' care and also patient safety, and we wanted to target zero harm for our patients. And what is it so different compared to traditional risk management and the current? So traditionally, we are doing more reactive approach on risk management. We only learn when an incident happens, then we will conduct a root cause analysis, which is a RCA. So from a specific events that happen, we learn from it. So it's a very reactive way. We did not prevent a harm from happening. So what we want to build in now is we also have to think proactively on risk. Before the events happen, we need to make sure that we have hypothesis or we predicting this could be happen, and we have preventions or control in place to prevent such risks from happening. So I will share with you on how do we do a proactive risk management in SGH later on. So we also comparing the method that we're using in SGH in Singapore. Is it standardized across globally? So we also do research on papers, and we found out that actually for risk management, the way of doing it, the tools that we use is actually very similar across the entire internationally global. The value of it is actually we need organization stability, credible, and also a resilience to look into this risk landscape. And how to do it, we actually will discuss this on the enterprise risk management later on at the end of the presentations. But the method of using it is similar across entire internationally.
I think Jeanie,
And the other thing, pause
just
here.
to add that it's because it is internationally aligned, we are able to compare later on when Jeanie go through our resource of surveillance information. We are able to make some alignment because it is the same methodology and principles adopted. Yes.
Then the other important point that I want to emphasize today is about leadership support. So what we have been facing is we do not want it to be mandatory task that is a top-down forcing you to do a risk management. So for SGH approach, we also try to get our leaders to understand how the team is doing risk management, for them to understand the importance of this work, so that they will see the value of why the staff have to do a risk management. By looking at this, we think that leadership support in this risk journey is very crucial. So for SGH, we actually able to get support from our chief risk officer and also our quality officer and even our clinical med board, chief med board, CMB, to get support and endorsement on our approach. So this is to emphasize that leadership and governance structure for risk is very important in SGH, which I can share with you the structure of SGH in my next slides. And the other important point that I want to highlight is about risk-aware culture. So most of the people do not do risk assessment until there is very high loss frequency, or they only do buy insurance. Example, when I want to buy a car or when I want to buy a house, it's mandatory that they have to get a car or house insurance. But because in Singapore it's mandatory, everyone have to get this insurance. But I think for personal insurance, then that is not mandate. So people do not see the importance of getting that because they haven't met the high loss frequency. The other way of getting people to think about the importance of risk is when they really do a risk assessment and something happens to it, then they will find a gem of risk assessment. The other way of building this risk-aware culture currently is we're doing a lot of publications with real story to make people aware that, oh, actually risk assessment is very important in my area of work. Or the other way for people to learn about risk is when something very bad happens. Example, the MON event that I showed you just now. Once people look at that news, then they will get more aware of the risk. And the other way is when people feel uncertain or fear, then they will start to think about, oh, what could be the risk if I do this, if I make this choice. So we are also trying to build this risk-aware culture. So actually, just to share that over the years, with our effort putting in, we do show a great impact on the importance, the awareness of people started or willing to do risk is actually growing. So by comparing 2023 to 2024, there's a 200 to 300% of increase in the staff in SGH are willing to engage and perform risk assessment. So I would like to take this opportunity to share with you the structure of our risk in SGH. So for SGH, we are led by this council called ERMC, which is an Enterprise Risk Management Council, which is chaired by CRO, our risk officer, and also COO, which I think Jillian shared earlier on. Then this team is led by a secretariat from our CPO office. And we actually split our risk council to two different arms, which is a non-clinical arm and also clinical arm. So for us today here, my team is actually looking after the clinical domain, patient safety, led guided by Patient Safety Council. So we are looking at the clinical risk management for the SGH. But I also like to share that we have another team that look after non-clinical domain, which is our HR department, our finance, operation, even our research and educations and IT team, or our new AI office. They have to do risk assessment as well, but they are leading by another team which looking after on the non-clinical risk. Okay, then after we submit all our risks to this council, they will actually oversee the entire risk in the SGH landscape. Then subsequently, they will submit all the risks in SGH to Sing Health level, which is led by Office of Risk Service, which is ORS. Okay, and I will let for clinical.
Yeah, just like to add on that for this one, I think what are alluding to is it's funneling up approach. So from the ground level, which are the clinical departments, the services, it's for them to identify their risks, which are the divisions that you're seeing on Jeannie's slide, the right-hand slide, and risk from different domains, be it clinical or non-clinical, go and are being consolidated at the Enterprise Risk Management Council. It is to assess whether there are overlapping risks from the clinical or non-clinical instead or a systemic issue that is brewing for the whole organization. At the cluster level, there's another way of funneling up and consolidating all the different risks across the different institutions, which I shared with you just now about the hospitals, the centers, and the polyclinics that are subsumed within Sing Health. With this funneling up approach and also downwards communication of risks that are identified at cluster level, we're able to have a more robust approach of identifying risk accountability at all levels. I think that's the emphasis and the governance structure we have at this point in time in Sing Health. Yes, Jeanie, may I continue?
Then the next slides, I will zoom into the clinical domain risk and how we collaborate with the stakeholder to do a risk management for clinical domain. So as you see, we have many clinical domains here, including our nurses, pharmacists, and also allied health. And each of the divisions have multiple departments under them. So we also funnel up from the departments to their divisions. Then for the divisions to submit to us, which is the clinical risk management team. And we have to bring up all the risk concerns from even the department or divisions level. If there are major safety concerns or high risk item, we will bring this up to discuss at patient safety councils, and then we will bring back the discussions to the individual department or divisions. And so just to share with you, like we have from department to divisions, then to upper patient safety council, and we also funnel it back to them if there's any conclusions or decision made at a higher level to them, to share with them what are the mitigations that the senior management can help them in their risk management.
I'd like to, I just like to build on this. I think what's important is, as what Jeanie mentioned, at all levels, accountability is very important. And having champions within the departments and also at the division level who are risk aware is also a critical component. So you may see that council is not taking away that accountability from the departments and the division to drive their own risk mitigation, because at the end of the day, they are the process owner. It is not going to be a sustainable system if everything resides at the hospital level. That said, the importance of where the council sits and eventually ERMC is to look at systems risk or risks that are cutting across multiple domains or multiple divisions, and from there identified a more streamlined and efficient approach to resolve the risk. Instead of at an individual division or department level, they are identifying and mitigating it when in fact it may be a systemic issue. So the key thing here is accountability at all levels, but we're also aware as to which of the problems need escalation and addressing at a management level. Yeah, that's the key message for this. Yes, Jeanie,
especially those risks that belongs to non-clinical domains. Sometimes it might identify at our clinical arm. So at the higher level, we will bring to the IT side or the human resource side on the issues or risks that they have been identified.
Yes.
Yeah, so this is the risk surveillance that we are sharing just now. So we actually looking into risk signals or risk that is happening around the world. So we actually collect data from not only in-house SGH data, but we also looking at WHO patient safety concern or even the ECRI top 10 patient risks. And we wanted to know that what are the patient safety concern or risks that has been highlighted in international level. But for Singapore, we look into the MOH serious reportable events that they will share across the public institutions. So serious reportable event is the events or incidents that is already happened and which might need to do a RCA, a root cause analysis. So every month we will receive report from our Ministry of Health on the cases that is happening around Singapore. So from there, we actually can learn from incidents that is happened outside SGH, and we take a proactive approach to learn from the incidents from there so that we want to prevent it from happening in SGH. So it's a proactive risk management approach. Okay, so and so we combine all these risks together and we analyze it against our in-house data. Then we will share across all the clinical divisions on what are the risks that's actually happening around you. So this is
Jeanie,
one of the
back to for the MOHSRE, you may be
yep.
wondering because just now Jeanie mentioned about we have moved from the traditional to the new way of approaching risk. As what Jeanie emphasized, so in Singapore we have a patient safety and quality division in Ministry of Health, and the intention of that is more on systemic improvement. Rather than so our serious reportable events are very clearly delineated from any legal implication because we do serious reportable event analysis using root cause analysis methodology to assess systems improvement. In terms of how do we then make use of that as proactive tool or data points, as what we call this, whatever you're seeing as risk signals, these are data points. Are those things that may have not happened in SGH, but may already be occurring in another cluster in Singapore. And our ministry provides all the different clusters with information on those events that have already happened so that have a mechanism to avoid it, or perhaps learn from best practices as to how it has been mitigated in another institution. So it is a very information that is intended for systems improvement nationally. And these are risk signals that we're using to help the division to further identify any risk. Because sometimes you may just see what you know, but giving them this additional information opens up the perspective of other risks that they may be blind about. Yes. Jeanie, you can continue.
So this is the example of the international sources that we collate every year. And this is actually from ECRI Health Tech Hazards and also ECRI Top 10 Patient Safety Concern list. So every year they will refresh a new top 10 list that we can learn from it, but it's not always applicable because in Singapore and or in Asia, our risk could be different, but it's actually quite a good source that we can reference to. And the other framework that I would like to share today is other than risk surveillance that we are doing for our team, which is the risk signals, we actually also do risk analysis by using different risk assessment tools, which we will go in detail on the next slides. Then after that, the most important part is not only to put in a lot of mitigations or controls through your risk assessment tools, but we have to ensure that the sustainability is there. We have to make sure that the action owner, the owner of the risk, did do monitoring of the effectiveness of the mitigations, do some data collections or audit and compliance monitoring to ensure that what they have put in is useful. And the other part that we try to enhance this entire risk management framework is by providing training. So we are doing actually quite a bit of ERM workshop to teach them how to properly do risk assessment by using the correct methods and risk register coaching. And we also do provide an individual review coaching to the team when they have a special projects that they require risk assessment. So these are the commonly used tools that I would like to share today. The first one is on risk register. So for risk register is actually a risk bank that we call it as a risk list within your area of work. So for example, these divisions can go back and think of what could be the possible risk for my divisions. Then they could collect it in a list. Then they have to ensure that they have mitigations in place to target on this specific risk. The other risk assessment tools that we actively using is Enterprise Risk Management Review, which I will show you later on. Then risk assessment metrics is the one on the right, which is we have this impact and likelihood heat map metrics that we have to rate and score each of our risks. Then we would know that what could be the very high risk or high risk item that I should be focused on. Then with this metrics, it's very easily we can see where is your risk and what you should target. The other method of doing risk is actually simulations model, which I can share with you on one of the cases that we are doing in SGH. Then for RCA is actually a risk management tool as well, but it's on incidents that already happened. So go in details. The first one is our simulations model. So for simulations model, we have been actively doing it in SGH. So one of the example of this is one of the incidents happened, and the recommendations is we have to use simulations model to examine if this method works for my patients. So they actually sorry on my charger. Okay. So we actually place the for this case is the patients is a patients that fall off from the OT tables. So the recommendation is to replace the gel pad that they usually use to secure the patients on the OT table. They plan to change it to a vacuum bin bag, but I'm not sure that if these recommendations will work or not. So by doing a simulations model, you will know that if the recommendations from this RCA, is it feasible? So for this case, we actually form a team, a multidisciplinary team that has anesthetists in place, the surgeon, the nurses, even the human factor specialists come in place when we're doing this simulations model. And we try to position the patients with different weight, so we call it different model. So patients which is lesser than 60 kg, patients who are around 80 kg, and who are more than 100 kg. So with different weight of the patients, when you lie on the OT table, you have to manage it differently. Then we also position the patients in a different position. We do have a head up and head down positions. So by doing in different model, then you can try to position the patients by using different aids. So you can try and see if this patient with this small model, I put a gel pad and Velcro strap, is it feasible? Will the patient drop off from the OT table? Or if we should use a vacuum bin bag. So by using this simulation model, we actually able to know that which method is the best way for different size of the patients. And other example of simulations that we always do in hospital is, for example, fire drill exercise. So while doing fire drill exercise is a simulations to predict what could happen when a real fire happens. So they try to do a real fire drill exercise. Then they realize that, you know, when the fireman came and there's a lot of water piping, water hose lying around, actually it blocks the us to wheel the patients out from the ward, which could be a risk. So by doing a simulations model, we could identify new risks that we might not predict at that point of time. So just to share with you, simulations model is getting more and more familiar over the years, and it could be something that we can look into for hospital healthcare risk management. Then the other examples that I want to share with you is on risk register. So we do have risk register as our annual exercise that we do with our clinical divisions. So with risk register exercise, every department has to submit their risk to their division level. So at a division level, they will scan through all the risks that submitted from their individual department and harmonize the risk. So they will look into the risk and identify what could be the risk that have to be overseen by my division level. So by looking at that, for example, with all the department, it could submit 100 risks to the division. But when the division review, it could be multiple risks that have similar problems, then they will combine it together to consider as one risk. So every year, the divisions will submit their risk to us, and they have to rank their risk into by using the heat matrix that I shared just now, the impact and likelihood. Then they will let us know what is my very high risk, medium risk, and low risk. So over the years, every year we will collate the risk from individual divisions, and we will come up with this enterprise risk assessment at a zoom out landscape. Then we will have actually 51 individual risks for our entire clinical domain. So with these 51 risks that we identify across entire clinical domain area, we actually part the risks according to their impact and likelihood, which we call it as their risk rating. Then we could easily see where are our high risk items that we should highlight to the senior management and ERMC to let them aware that this could be the potential risk that they have to look into it. And if it's related to non-clinical domain, then we should share with them that these are the risks that we have been identified and could be related to them, and we need them to see if the mitigations is feasible. And the other thing we are doing is we classify all the risks that we collect into specific risk group. So we wanted to know where are our risks and what are those risks. So we actually identify example, clinical process or procedure errors could be the high risk item that people or all the clinical divisions submitted to us. And for example, communications is another risk that has been repeatedly highlighted to us. So this could be with proper risk classifications, we can identify which area of risk that we should focus on. And the other method that we're using is after they perform a risk register exercise, then they should the division will identify what are their top risks. So with this top risk item or topic, they will do this exercise called Enterprise Risk Management Review, which is this 5 steps process. So with this topic that they identify, they have to set a goal and objective. Then with that, then they have to deep dive into the risk events and write a proper risk statement. So we even teach them how do you properly phrase your risk statement so that you can properly target on the mitigations. With each individual risk, you have to rate the impact and likelihood of that specific risk and tell us what are your current mitigations or control in place for this risk. Then please rate the effectiveness of your control. So if you already have many control in place, and it should be turning your risk into, like average risk, no longer high risk. But if after putting in the mitigations and you still think that this risk is not well controlled, then you should probably think of either to replace your current risk with something else more feasible, or you could add in new mitigations to make this risk to have lower down the risk rating. At the end of the day, the step 5 is very important, which is to monitor the result of your mitigations that you put in. If your mitigations is not effective, then should consider to make changes as needed. So this is a 5 steps process that we encourage our team to do it, to properly think of what is your risk, what is the controls that you have in place, how effective it is. Then the system will auto-populate to them to show them with this control, what are your risk rating, and do you still need to add in more mitigations to overcome this risk.
I think Jeanie,
So
just
while
do some time check. I'm not sure if we have 10 minutes remaining. We have 2 more slides, Steve.
Yeah, that's okay. That's great.
That's okay?
Okay.
Okay. Yes. Okay.
Yeah.
Yes. Yeah.
So by doing a ERM review, we always encourage the clinicians to look into it in a holistic way, because most of them is from the clinical background. They will probably focus on the clinical and patient safety risks, and also the operational and strategic process risks. But at the same time, when we are doing an enterprise risk management, we should also consider all other risks, for example, human capital risk, our finance risk. If this happens to us, what are the legal impact or reputational impact could come to us? Then what are the IT risks, and if there's any educations and training risks as well. So it's just a holistic way of looking into the risk assessment to avoid any potential risk that we could have missed out. So this is the way that we teach them how to properly do a risk review.
I think
And the last
just to build on the previous slide, this is useful
previous
as the assessment of risk move up into the management ladder. Because, for example, at the department level, the focus is very much on clinical. But if they don't look at the other component of risk, at the division level, the resourcing of let's say the work plan, are there any implication on education and research at the division level? So the more it moves up, the value of the different components of seeing risk at a different lens becomes important. Mm. So that's why it is critical at the department level. The focus is not just on looking at clinical processes, but what are the other risks that accompanies that particular clinical risk. Yes, just to
yeah
emphasize on why it becomes why there's a need for a holistic review of a particular risk. Yes, Jeanie,
mm,
I continue.
yeah. And some of our clinicians or our clinical domain who are more mature in risk management, they actually do use this risk ERM review process to identify what could be the needs their division require. Then they actually tie along this risk that they have identified together with their work plan, their annual work plan.
Yes.
Then, so the last part is very important. So, what are the value of me doing this? So, of course, we need a career progressions plan for the champions or risk persons that are doing this piece of work. It's not something that I do it now, then there's no, next day I can abandon this piece of work. So we actually encourage the people to do risk assessment, risk management, and at the back end, we are supporting them in this journey. We do provide them proper training, proper e-learning materials, and we give them a workshop. And at the same time, if you want to go up the ladder on this risk journey, we do provide international conferences on patient safety or risk specific. So example, ASHRAM conference. Then we also provide ERM certification courses that is available in Singapore. So currently we have, like example, a new one that our Sing Health collaborate with Deloitte to do a healthcare specific risk management program, which we do send our risk champions our patient safety officer to attend such courses. Then eventually they can be trained as a trainer of this ERM journey, then could help us to, further uh, bring out this knowledge to everyone on the ground. So is there are career progressions for this risk journey. Okay, and we are at the end of the presentation. There's a lot of information, and in 1 hour, if you have any questions, can drop drop us a text or can voice up.
Great.
Yeah, I
Thank you
think
so much.
to wrap up on it's a journey, it's a
Mm.
change management journey that SGH Clinical Risk actually went through. It started off in 2022, and it's trial and error, and you have to really find the early adapters before you really try to push it to the ground for understanding. Second component is capability building, as what Jeannie mentioned. So you have to bring awareness to identify even the early adapters before they have so that they will have a better understanding of the need for it. The third part, perhaps, is the storytelling, as what Jeanie mentioned. It's tugging the heartstring so that they can see the value of it, and they're not seeing it from a very administrative perspective, but looking at it from the need to do it. And perhaps the last bit is more on making it easy. So the team have went through a lot of iteration in making a very complex topic something that is more palatable and bite-sized. And as what Jeannie said on the accomplishment, I think we are moving the needle and we're quite happy with the progression, although we are continuously iterating and improving. Yes. I think that's the end for our session, and we will value your feedback later on, which we can flash again. But we're opening up for questions.
Great. I think thank you so much. Really appreciate it for sharing this important piece of knowledge. Because the perspective that you have shared, actually, some of the points are quite unique and can be definitely imbibed in our settings. So really, deep thanks to both of you and to Singapore General Hospital for sharing the best practices. I will now request there are some questions which our attendees have, and one is from Bobish. Bobish, would you like to ask the question?
It was a really nice lecture and
Thank you.
training. It was about all about risk management, enterprise risk management and all. Actually, ma'am, we would like to know little more information about enterprise risk management. It's mainly
Mhm.
about risk treatment plans what you adopt in your hospital system. And second question is, what are the opportunities you identified from risk in your hospital setting?
I didn't get Bobish. Can you help repeat the first question?
The first question was related to enterprise risk management. What are
Yeah,
the
the
risk treatment plans you are identified for enterprise risks?
so
How
it's
you are
very
treating?
it's very individual, depends on what are the risks. So example, if the topic is on AI risk, then the treatment of that risk in specific is example is on the legal impact. So if your AI give you a wrong output, you need human in the loop as a treatment, a mitigations to target this risk. So the treatment plan, the mitigations for individual risk is very different,
Mm-hmm.
and it will be the owner of the project itself who monitor the effectiveness of this treatment. Yeah. Do I answer your questions? Yeah.
Maybe
Yes, yes.
I'll build on what Jeannie mentioned. So if you can see, she mentioned that some of the risk signals are ECRI. And even Ashram, when we participated in the conference. So from that, those different platforms, there's identification that AI is an up and coming risk. So early this year, actually we are in our um, development of AI governance. So because of that identification that there are already a lot of AI tools that are being deployed, but the question is, are there potential patient safety risk? Because of that, it went through an enterprise risk, if you wanted to call it that way. So at an enterprise level, AI risk is already has been seen as a thing that we need to look into. Because of that identification of that AI risk, then it kickstarts the process of, do we have governance? Are there any certain guidelines on how different domains, different departments can deploy AI methodology or tools safely? So it did trigger us to look into it because of the risk signals that are coming from different sources, and now we are embarking on developing mitigations for it.
All right. Thank you.
Which is to form
The
an AI
example.
governance team.
Correct. Mm-mm.
So the other question is on what are the opportunities you identify from risk. So it
From the
depends on if your risk is already happened, which we call it as a incident reactive way, then we will have recommendations to actions to target on these specific events. But if it's a proactive learning from other institutions or ECRI, then there are opportunities for us to put in mitigations to prevent it from happening. So take back the example of AI. We know that AI is ongoing and many things is happening. Then we foresee that could be a future risk. That's why we are building a governance for our hospital to govern these AI projects. So these are the opportunities for us to build something before it happens. And
I'd like to
hope I
build
answered.
that as well. Yeah. So recently, because one of the divisions also identified, so there is increasing use of cell gene therapy. So because of the departments and the divisions surveillance or scanning that there are more clinicians that have been tapping on this mode of treatment. But are we safe in terms of deploying it to the patient? So now, because of this exercise, the risk opportunity was in there. Now we're looking at it as, is there a governance framework for cell gene therapy? What does the ministry or nationally, what's the guideline? And what should we be looking into in terms of deploying such treatment to our patients? So that's an example of risk opportunity for a particular risk that we pick up. However, as a whole, I think the opportunities in the whole learning of risk management is what I've mentioned a while ago. You need to build capabilities, you need to make it easy for them to understand. And those are basic or foundation so that you bring a better risk aware culture.
Thank you so much for the answer. And one more question is there from Mr. Mukesh. He's asking that what are the internal data sources you are using in your facility for the risk identification or assessment?
Internal data sources. Jeanie, I let you answer.
Yeah, so we actually have this system called IRS system, which are storing all our near misses, our incidents that already happened. We call it errors. Near misses is something that have yet to reach the patients, but be able to pick it up. Yeah, we also do a ground walkabout. So we have a leadership teams who go to the ground and talk to the staff and get sensing from there. So when we do walkabout around the hospital, talk to the people on the ground, we're able to identify what could be their concern, because their concern are things that they are worried daily could be a potential risk that could happen. And yeah, so do I answer your question? So all this is our internal data source that we are using, and also the SRE, the serious reportable events that are happening in SGH could be our data source as well. And we use that, all the sources, we combine it together and get to classify them into a proper risk group that I mentioned just now, like is it clinical process problems or is it communications problem, then we're able to tackle the area of risk.
To add on to that, I think just now in the beginning we've shared to you that we are all in one team, and we are privileged. I think I call it privileged for the team to have access to data, patient data records to our EMR, and that's important because we look at clinical incidents and clinical reviews. So we are also embarking because it's a lot of data, but data without analysis will not be useful at all. So we are also deploying AI methodology so that we make sense of this vast amount of data. And if we're able to do so through the different platforms, as what Jeanie mentioned, we have incident reports. You don't react to reports. You by right, you should be trending it. So based on those trends, what are the risks that are brewing? Then we also have information on clinical reviews. Based on the clinical reviews on our mortalities, morbidities, are there significant care lapses that are also building? So those are data points that we have our own way of looking, but I feel that there are much more opportunity to uncover potential risk. And for this, we are already deploying AI methodologies like LLM so that we can extract those care lapses, trend it, and then if you're able to trend and see the data, you deploy your risk mitigation strategy. Yeah, so it's a journey, as I've said, but it's actually an exciting journey that we're embarking on.
Great. Thank you so much. Mukesh, is there any other further questions from your side on this?
No, thank you so much. Thank you so much for the information.
Any other questions from anyone else?
So if there are no other questions, we would appreciate if you can scan the QR code, give us some feedback, and if you want to further learn more, do connect with us on LinkedIn.
Great. Thank you so much, Jeanie and Jillian. Really, it's a very insightful presentation, and we look forward to stay connected and learn more from your team.
Thank you so
Thank
much.
you so much. Thank you.
Thank you. Thank you, everyone, for attending the same.
Have a good weekend, everyone.
You
Thank
too,
you.
guys.
Thank you.
Thank you. Bye.